Welcome back, everyone. So, thank you for coming a couple hours early if you join me. Otherwise, you can follow up on the archives. But ask me anything every Monday, generally 6 p.m. Central Time. I put up a story early Monday morning. You supply the questions, I supply the answers. I do my best to try to help you guys out every week. Try to prevent these heart attacks and strokes because I'm tired of every 40 seconds somebody having an event. Hopefully you guys had the ability to listen to the podcast I did with Dr. Lyon recently. Went through a lot of the facts on how to optimize the endothelial function. We talked about a lot of interesting topics, including GLP-1s, testosterone, the keto CTA trial. So if you haven't yet seen my most recent podcast with Dr. Lyon, go to YouTube, check it out. I think it's got 11,000 views already. So a few housekeeping things. I did sign a letter of intent with the Canyon Ranch to have a retreat there. October 31st to November 2nd. If you're potentially interested in this event, I will have more details coming soon. I'm waiting on some of the information from them about an 800 number for people to be able to schedule their accommodations. There's no fee from my standpoint to attend this event. I'm going to plan to be doing some hikes, so if you want to join me for the hikes in the mornings or go to some of the meals with me, happy to meet up and we can chat. But if you're interested in signing up just for an email from me when I got more information, if you go to my website, drtwyman.com/retreat, there's just a button link that goes to a Google form just so I connect you to me. And once I have information, I'll send out an email, and it's suspected probably in the next week or so. But those dates for the Canyon Ranch, it's going to be October 31st to November 2nd. I also want to let you guys know that I'm still working on that school community, my heart attack preview community. It's something that I have a few kind of courses already built up, how to review your own labs, how not to die. I have a podcast in there that is exclusive for you guys. It's the best of my most top requested 30 podcasts I've ever done. Used AI to summarize it into a 15-minute podcast. So if you've not followed a lot of my details before, it's a good summary of those things. So I will have more information about that. It's going to go officially live August 1st. I may have some kind of teasers to get you in there. There should be a 7 free day trial if you're interested in utilizing that. I'll put a link in my story later today. And then the last piece of housekeeping is that I talked about this Connect QT device at the podcast I did with Dr. Lyon. This monitors your blood pressure, not only your brachial, which is the blood pressure in your arms, but also the blood pressure, your central pressure, which your heart, brain, and kidneys all sense. So I was able to reach out to the company. They did provide me with a $70 off code. It's not a affiliate fee for me. It's a complete discount code for you. So I get no reimbursement recommending this device. It's what I personally use for myself to check blood pressure, and it's what I use in my office and recommend to my patients. So I will put that in my story as well later today. So let's jump into the questions here. There's quite a few, so excellent. Must have a lot of new followers. So, all right. So they need more doctors looking and talking about circadian biology in light environments. Absolutely. The Quantum Biology Collective is such a group of individuals. I've been a part of them since they launched. So if you look up the Quantum Biology Collective, you can find some other doctors and healthcare providers talking about it. How to make an office with no windows, more circadian rhythm friendly. That is a complicated one. There is no replacement for sunlight, full stop. But if you absolutely can't have any type of windows, then old incandescent bulbs are probably the best. Or if you can use red LEDs, if you're in a location that allows that, that would be probably the second best. But typically, would recommend just going outside as much as you can, every hour or two for 5-10 minutes, and just trying to get some light in the eyes. Even if it's only for like 15 seconds and going back in is better than nothing. But for those that have seen me in my office at Apollo Cardiology, I have a plant in the corner. I often talk about that plant. If I kept a tarp over it the whole time or kept the windows down, it's not going to grow well. Same thing. So if you're in an office building with no windows, you need to be outside at some point. Next question. What does a 3% CT score mean? I don't know exactly. Maybe it means they were a third percentile, which would be very low for age, which is good, but could also be your score. Any score above 0 is abnormal. So 60-year-old female, Active lifestyle, excellent. Exercise is one of the best anti-aging drugs that you can utilize, but I don't know exactly what it means. Plaque is common as you age. The higher the plaque burden, the higher the risk. So if your calcium score is over 400, that is high risk. If your calcium score is over 1,000, that's very high risk. So you'd have to know what the total calcium score test is to know the risk. Rapid fire style. What is my recommended supplement stack for the average person these days? Sunlight, and that is it. I do not have a routine supplement stack for people. It's based off of your N1. So what is your context? What is your plaque burden? What deficiencies do you have on lab work? So no routine supplements. How can we compensate for the lack of proper sleep to protect the heart? So I don't know exactly what you mean by compensate. There really is none. You need sleep to repair your mitochondria for autophagy and apoptosis to occur. So ideally 7 to 8 hours of sleep. The sicker you are, the more sleep you need. The healthier you are, maybe less. But there is no compensation. So personal example, when I was a resident, I slept in the hospital every third night. Was often awake for 36 straight hours. I had very poor sleep for 3 years, essentially. There was no compensation. You just made do, and you operated at a much level of suboptimal function compared to people who would sleep, on a routine schedule. So once I was out of training, I never went back to that type of lifestyle. My brain works much better, and I'm much happier sleeping, good 7 hours every single night at least. Is it safe to get your heart rate up if you have coronary artery disease? The short answer is yes, likely, but I can't give one-on-one medical advice to this audience, so I would need to know what kind of coronary disease, what type of interventions, what medications the person is potentially on. So can't tell for sure, but a calcium score of 70 is not high risk as previously stated. 400 is the high risk category. So have to talk to your current doctor, what kind of exercises you've done in the past, but then I can tell you, what is your exercise limitations, if any. What tests are there to see if your mitochondria are sick? They're not a exact lab test or anything that you can do. It's more like, do you have any chronic medical issues? If you have a heart condition or brain condition, often you have a mitochondrial issue, and the tests dictate, what you do is based off of where the organs are damaged. How to get them healthy again? That's the optimize your light exposure, grounding, sleep. Mitochondria take its cues from the environment. So you want to collect electrons from the environment by grounding, getting sun exposure on your surfaces, getting the water in your body to be charge separated. That's where I would start. And then, you could do advanced blood work, through Boston Heart Lab, Cleveland Heart Lab, and figure out things that can potentially damage the mitochondria. But oftentimes it's about just cleaning up your environment, limiting artificial light at night, blocking EMF whenever, capable, particularly where you sleep. Next question is high LDL of 170 with HDL of, can't read that number, 61. A good indicator of heart disease? No. Blood does not indicate heart disease. Heart disease is an imaging test. So whatever is in your blood, that's interesting, but you have to look at what's actually in the arteries. So for the carotids, carotid intermedial thickness scan. For the heart, CT coronary calcium score, CT coronary angiogram. If you're having symptoms, you're going to have an invasive coronary angiogram. You can look at abdominal aortic aneurysms. You can look at ankle brachial indexes. Those are some of the starting tests you can look at. You have 60,000 miles of blood vessels. You got to look to see if there's plaque in the arteries. And you're concerned about don't want a statin. That's a personal decision many patients can make, but it's all based off of risk. So if you have a calcium score of 0, statins may not be indicated for you. If you have a calcium score of 1,000, you have a 1 in 3 chance you'll have a heart attack in 10 years unless you do something about it. So statins are just tools. Use the right tool for the job, get the arteries tested, and then you know where you stand. There's a follow-up question, basically. They've heard me mention a CT angiogram. What's that, and what does it show versus a calcium test? Great question. So a CT coronary calcium score is a non-invasive test that looks at hard calcified plaques in your heart arteries. Does not require an IV, does not require medications to slow your heart rate down, and you don't have to have normal kidneys to get it done. The calcium score test takes under 5 minutes, and generally cost-wise is $100 to $300 US. A CT coronary angiogram is done in the CT scanner, but it takes more preparation. You often have to take a beta blocker to keep your heart rate under 60 beats per minute. You have to have an IV placed. You should have your kidney function checked before then, or they'll check it at the time of the CT, because you have to have normal kidney function because the contrast is going to be filtered out of your kidneys. And then there's going to be a higher radiation load and also a higher cost. A CT angiogram, depending on where you're getting it done and if you're paying cash or not, may be anywhere between $650 and $3,000. But a CT angiogram can assess for how much stenosis is in your arteries, and if you add AI analysis with it, you can often then quantify how much soft plaque is in the walls of the artery. Think of plaque as like an iceberg. The majority of the plaque is in the walls of the artery. It's not until much later does the plaque kind of occlude the lumen and block blood from getting downstream. Both are good tests. I usually recommend people start with the calcium score test. If they absolutely are intermediate risk and they really want to know, are they higher risk or they're on the fence about taking medications, the CT angiogram will tell you, do you have any plaque in your arteries? Because I've definitely seen many, many people with calcium scores of 0 that still have significant soft plaque in their arteries. Next question, what is the average beat per minute for a 47-year-old woman who's physically active? In all comers, 60 to 100 beats per minute is normal. Under 60 is considered bradycardia. If the person is generally more than just moderately physically active, the resting heart rate generally will be in the 50 to 60 beats per minute. But I believe the lowest heart rate recorded and somebody who's not having a cardiovascular problem and needing a pacemaker, I think it was Miguel Indurain. He was a Tour de France winner. He had a resting heartbeat of 28 beats per minute. So, next question. The person says they have a coronary calcium score of 2,580. Do you have any suggestions on how to lower it? So that's a very high risk score. I've seen scores over 7,000 before. But patients with scores over 1,000 need to be working with somebody who assesses that do they have ischemia. Sometimes a stress test is necessary. Sometimes an invasive angiogram is necessary to look for a degree of stenosis in the coronary arteries. Not everybody who has that type of score needs stents or bypass, but some will. There are no real drugs that are going to lower that type of score. The goal is to stabilize that plaque. Sometimes the score will go down, but that's not necessarily the goal. The goal is not to have a cardiac event. So you have to figure out what has damaged the endothelium and endothelial glycocalyx. You have to lower oxidative stress and inflammation if still present on lab work, and use whatever, nutraceutical, lifestyle intervention, supplement, medication to lower the lipoproteins down to probably the 5th percentile. So I would be shooting for an ApoB goal of 55 or less, and an LDL particle count less than 700. I definitely have patients that, have had scores higher than this and not had cardiac events, but it takes some detective work to figure out what caused that high risk plaque and what you need to do to stabilize it. All right, next question. Person's left ventricular function is down at 28%, 1 year post-op from a 3-vessel bypass surgery. What are the best ways to improve the ejection fraction over time? So standard medical care, of course. So beta blockers, ACE inhibitors, medications like spironolactone, and medications like an SGL2 inhibitor, Jardiance. That would be the top 4 medications to be on. And once you've kind of maximized those, there are some other mitochondrial support supplements that might be, considered. Dr. Sinatra used to previously write about many of those, doing things that can optimize mitochondrial function. So grounding, sauna, potentially red light therapy, optimizing sleep. All those things are necessary to improve mitochondrial function because ischemic cardiomyopathy requires the kitchen sink to be thrown at it to improve pump function. Question, surgery for an ascending aortic aneurysm, 4.4 centimeters, question mark, calcium score is 52. The calcium score is not high risk, so not likely to have obstructive coronary disease, but wouldn't know what the question is without knowing, is the aneurysm new or is it increasing in size rapidly? The majority of the time, the ascending aortic aneurysms, unless somebody has a genetic predisposition, they got Louis D syndrome, they got Marfan syndrome. Oftentimes, they're not going to be doing surgery for aortic aneurysms until it's over 5.5 centimeters, unless it's rapidly progressing. What are my thoughts on urolithin A and its bioavailability? It is an interesting supplement that may help with mitochondrial biogenesis. I'm not personally taking it at this time. I've seen some of the research. It is interesting. It just really depends on, I always tell people they have two budgets for their supplements. There's how many pills are they willing to take in a day, and there's the number of dollars they're willing to spend in a month on supplementation. I think it's a useful supplement for some people, but it tends to be one of the pricier ones. So I tend to focus more on the ones that affect vascular health first. And then if people's supplement budget, either pills or cost isn't a big concern, then I think it's very useful. Question about high lipoprotein little a of 225, high calcium score over 200, and then the LDL cholesterol is in the 1 teens. And they eat very little saturated fat. So the question, I don't know if it's like what's best diet. I mean, the template would probably be a Mediterranean-esque template, to start. So a lot of omega-3s, polyunsaturated fats that are healthy, the monounsaturated fat, olive oil, and then, doing things that you optimize for keeping insulin resistance down. So this is a case that I see often. LPLA, can double the risk of, inflammation and plaque in the arteries. So would focus on optimizing nitric oxide, looking at LPPLA activity, look at oxidized phospholipid ApoB, look at interleukin-6. If those are elevated, lower those. And then use whatever combination that you're comfortable with, statins, ezetimibe, PCSK9 inhibitor, potentially Nexletol, to lower the lipoproteins. Because the goal when you start having a positive calcium score with LPA is having an ApoB generally at least less than 70, and if you have other risk factors, potentially under 55. All right, next question. When doing high intensity exercise with very high heart rate, can the glycocalyx be damaged? Potentially. It does sense shear stress. So, it depends, what the health of the glycocalyx is beforehand. There is not a direct test for the glycocalyx. There's more downstream effects. But generally, if you have normal blood pressure, if you have normal, salivary nitric oxide testing, you can do that with some test strips from home, then exercise is generally protective to the glycocalyx. But if the glycocalyx has been damaged because you're insulin resistant or have, microplastics in your system or heavy metals exposure, then exercise, while beneficial to the glycocalyx long-term, can be short-term damaging, but it's that hormetic response that is potentially helping it. So it's something that I wouldn't dwell on, but if the person is asking more about, are they a high intensity person where they're doing like Ironmans or century rides on bikes, then the concern is that you're overdoing it, and that oxidative stress and inflammation will make it more likely that the glycocalyx will not be able to recover. So exercise is a drug. No exercise is bad. There's a large sweet spot, but overdoing it can definitely cause issues. All right. Efficacy of metoprolol tartrate for reducing PVCs in patients with normal blood pressure versus the risk. So, premature ventricular contractions, they are common. They're often benign, but sometimes they're problematic for people. If it's bothering the person enough where they can't sleep, they can't exercise, then maybe it's worthwhile to use a beta blocker to decrease catecholamines to see, does it help with the sensation that they're not feeling them as much. But just using a beta blocker to lower PVCs How effective? My experience, not that effective. You often have to look at, what might be driving it. Is it a electrolyte imbalance, particularly magnesium being low? Is it a thyroid function issue, overactive thyroid? Is it electromagnetic frequencies? I've definitely seen people wear their wearables, their watches, their rings, the Bluetooth causing people to have more PVCs. Keeping your phone in your pocket or your bra strap, definitely increasing PVCs in some individuals. So trying to find what's driving it is probably more likely to be beneficial than always just blanket using a beta blocker or calcium channel blocker for people. But I offer to people just because it may help with some of the sensations. But if they're not bothered by them, oftentimes just leave them alone. And then last pre-submitted question today. How do you get enough sun safely? Worried about skin cancer and aging. So your skin is photosensitive. If you get the right signals in the morning time, you tend not to burn. So this is the idea of hybrid tanning. So if you're out at sunrise getting the light in your eyes and on your skin, when UV light comes out later in the day, it's very unlikely you're going to burn. It is best to use an app if you need more assistance with this. So usually I recommend either the D-Minder app or the My Circadian app. And when you log onto the apps, it'll tell you where you're at in your general location, when the sun rises, when the sun sets, but it's going to tell you when the UV wavelengths come out. And it's the UV wavelengths that can injure the skin if you get an overdose of them. So depending on your Fitzpatrick skin type, so how easy it has been for you to burn in the past, you can basically get a prescription of how much sun you can get safely throughout the day without burning. All right. So we got the pre-submitted questions answered. We'll jump in here to any of the questions that pop up in the comments here. So somebody's talking about that they had a Connect QT and enjoyed it. So somebody says that they've kind of woken up with a low blood pressure for several days. Should they back off from blood pressure medications? Best to send a message to the portal, what dosages of supplements and meds you're taking, and then potentially will help you figure out which ones to hold off on. But yeah, for anybody who's, taking medication or supplements for blood pressure, don't stop them without talking to your doctors to figure out what it is. Sometimes, you may just need to hold one of them or, may need to change the dose. Scrolling here through the comments, seeing if anything else pops up. Can't tell what that word is, but it's likely LPA. So best practices to reduce the risk of high, looks like L something, but probably LPA. So 20% population has high LPLA. You don't generally lower LPA. The PCSK9 numbers may lower it 20-30%, but that's probably not clinically significant. So we're still waiting for the the antisense oligonucleotide medicines to come out with their trials later this year, early next year. So it's probably a year or two from the market really having drugs that effectively lower LPA by 90% or greater. So in the interim, you lower ApoB on the LDL particles using whatever tool, keep inflammation down. And I said earlier, the three labs that I always look at with LPA, it's LP, PLA activity, interleukin 6, and oxidized PL ApoB. If those are in the green zone on the Boston Heart Lab panel, and those the company that only does them, then LPA is not likely damaging your arteries. Question, how to optimize nitric oxide? 1, try to remove anything that's damaging your ability to make it. So avoid mouthwash so that you don't disrupt the oral microbiome. Avoid proton pump inhibitors and acid blockers. If you're on them, work with your doctors to get off of them, but you need stomach acid to make enzymes that make nitric oxide. UVA sun exposure liberates nitric oxide from your skin, so being outside. Somebody asked earlier about exercise. When exercising, blood flows across your glycocalyx and the endothelium, and nitric oxide is released. So up to age 40, that's the main way that people make nitric oxide. Then there's a backup pathway in your oral microbiome. So if you have nitrate-reducing bacteria in your saliva, when you eat foods that are rich in nitrates, which are the green leafy vegetables, the bacteria in your saliva breaks that down into compounds that ultimately become nitric oxide. So that's the lifestyle ways. And then there's companies that make nitric oxide lozenges and capsules, but sometimes it's doing blood work to figure out, okay, what's breaking their nitric oxide pathways and repairing those. All right, this is a good question, and I've mentioned it before in the podcast. So is LDL causal of disease, or do I think it's not about lipoprotein but easy water? I say it's probably about both. So the glycocalyx has easy water in it. If the nitric oxide that is released from that layer is healthy, the lipoproteins are repelled from sticking to that structured water. But LDL particles, the ApoB containing particles, they definitely are components of atherosclerotic disease, but are they causal in the only thing? No, you have to damage the glycocalyx generally first, and this oxidative stress inflammatory cascade kicks off as more and more lipoproteins get retained in the intima and plaque kicks off. So if you have healthy structured water, which basically is you have a healthy glycocalyx, it's much less likely that the lipoproteins retain in the lining of the arteries. All right. Well, I think I got to the bottom of the questions there today. You guys had a lot of good ones. I think I got a lot of new followers after Dr. Lyons podcast, so welcome. The game has been every Monday, 6 p.m. Central Time. I jump on here, ask me anything. The questions are pre-submitted. I do answer whatever ones pop up in the comments. Usually spend about a half hour answering those questions, help you guys really reduce your risk of having heart attacks and strokes. The only housekeeping stuff I had today was that I do have the letter signed with Canyon Ranch for the retreat, October 31st to November 2nd. I will have more details probably in the next week about what 800 number to potentially call to set up your accommodations. There's no fee from my standpoint to attend this conference if you want to go to. If you want to join me for some hikes and some meals or just learn what I do for my health and well-being, come to Tucson in October. I also talked about that I have a new school community being developed. It's going to be what I ultimately kind of transition my old Facebook heart attack proof group over to. I just don't really utilize Facebook. School has a better platform. I can make courses on it. I can share things on there that I can't share on the open social media platforms. So be on the lookout for my heart attack proof school community. It'll go live August 1st, which is the birthday for Apollo Cardiology, which my practice will be 6 years old at that point. And then for those that are still interested in working with me, I still do have some openings this year. We generally only work with about 200 new patients a year, and we're closely approaching our goal. So if you're potentially interested in working with me this year, go to my website, drtwyman.com. There's an application. A member from my team will reach out to you, set up a membership call or a onboarding call, and make sure that what your conditions are works for us, that we can help you guys the way that you want us to help you. So hope you guys have a great week. I'll be back next Monday answering your questions. So take care.